بسم الله نبدأ دكتور.
Greetings to all our audience from different parts of the world. Today, this is the third day of our first International Saudi German Hospital Madinah Stroke Symposium. We are honored to host you again in that unique scientific activities regarding the field of stroke medicine. Today, our presentations will be variable, like the previous 2 days. We are honored in the field of stroke medicine, Professor Dr. Ashfaq Shuaib, Director of Stroke Program at University of Alberta, Edmonton, Canada, who will present to us a presentation about acute thrombolytic therapy in acute ischemic stroke. He will take us into a journey away from the classic knowledge about thrombolytic therapy, but to hot areas in that issue. We hope to gain benefit and the presentation to be fruitful to you. Professor Dr. Ashfaq, you are welcome. We are honored to host you again, and you can start sharing your slide and start.
Thank you, Mohammed. It is always a pleasure. I love presenting to your group. I wish I was in Medina. You made a promise that next time, inshallah, we'll do it from within town.
Inshallah.
And we look forward to that. So I have about a 40 minutes.
That's a promise. In front of all audience, that's a promise.
In front of a big audience. All right, wonderful. So I'm going to be talking about acute stroke thrombolysis as we understand it in July of 2021. I have my slide that I need to move forward. I have no conflicts at all with this presentation. What I wanted to talk to you about was the following. You know, for all the audience, the important thing to keep in mind is that whenever you see a patient in the emergency department and you suspect an acute stroke, you have basically 3 objectives, very important objectives. The first, which is extremely time dependent, is to figure out whether this person is a candidate for reperfusion treatment. And reperfusion, as you know, is either IV TPA or IV TPA plus thrombectomy or thrombectomy alone. So my job today is to talk about IV TPA selection. Also, very importantly, these patients are extremely unstable in the first several hours, and they're at risk for complications. So the second thing you keep in mind is, as you're assessing these patients, is to avoid complications, and I'll have a slide on that. And finally, the first stroke is usually not as bad as the second one. So you want to make sure that you start putting together strategies to avoid the next stroke. So 5 objectives: stabilize the patient, confirm the diagnosis of the third of your patients. In our center, almost half our patients are stroke mimics. You know, migraines, seizures, functional, all those patients have to be excluded. And once you've done that, then you determine if the patient is a candidate for thrombolysis. And I will not be talking today about finding an etiology, as you have another person who's dealt with this topic. And once you do determine the etiology, you want to put strategies to prevent recurrences. So we'll focus only on the top 3 bullets in my presentation. So first of all, how do you stabilize the patient? You make sure that they're well oxygenated, make sure they're lying flat, because if you raise their head, in some patients that may cause unstable oxygen saturation in the penumbra region. Make sure the blood pressure is good. Hyperthermia is really bad. So if they have an infection or they have a fever, you need to treat that. You also want to make sure that you avoid aspiration, which is the most important cause of progression of severity of symptoms once the patient comes to hospital. So keep them NPO and watch out for arrhythmias. And the best place for this is a stroke ward or a stroke unit. Emergency is not a good place to treat acute stroke because they're not trained to prevent complications, etc. First thing, stabilize patient. Secondly, you want to confirm your diagnosis. Most neurologists take pride in spending a lot of time in assessing the patient and localizing where the lesion is. But in stroke patients, we say, you've got 5 minutes. That's the time when you organize your CT scan, and in those 5 minutes, you've got to make sure to find out whether this person has an ischemic stroke, possibly where the lesion is, and you pull the blood, make sure they're not hypoglycemic, make sure their INR is not prolonged, especially if they're on a blood thinner, because that would be a contraindication for TPA. And then take this patient for an MR, mostly, or a CT scan. Most centers will have CT scans, but some in Europe would have MR. And importantly, you also plan for vascular imaging. So the CT scan would be to rule out a hemorrhage. The vascular imaging would give you some idea of where the occlusion is. And then you do advanced imaging. In most patients, this would be a CT perfusion imaging. And I'll spend a lot of time on that. So you've secondly made sure that it's not a mimic. And then everything you do has to be very rapid. So in our hospital, rapid means this. If you were in our hospital, here's the CT scanner. We've got the IV TPA line ready. If their CT scan does not show a hemorrhage, so this is at the lower levels, this is at the higher levels, we do the aspect score, and we start our TPA. And if you notice down here, every month in here, we monitor the time it takes from the patient presenting to the hospital to the time the IV treatment starts. So the IV treatment almost always starts inside the ER, once inside the CT scanner, once you've ruled out a hemorrhage. Now this is for patients presenting in unless under 4.5 hours. If they're more than 4.5 hours, then of course we would not be stopping here. We'd also be doing additional investigation before we give them thrombolysis. And I'll explain to this as I get along. So under 4.5 hours, do your CT scan, rule out it's a hemorrhage, and treat as fast as possible. This is what we call our ultimate in speed. So if you don't see me, here's me. This is the side of a main road. This is our ambulance. It's called the mobile stroke unit. We use it very frequently. And from the inside, you can see we've got a CT scanner, we've got a camera up here in case you want to connect with the hospital. And we will start treatment in here with IV TPA. So it's important that you treat them as fast as possible. So for my first segment then, determine if the patient is a candidate for thrombolysis. Here's my summary. You cannot control the onset to door time, right? You can't control that. Some people may know it's a stroke, others may not. And so it may take anywhere from minutes to hours for them to come to hospital, but you can improve the door to needle time. You want to be good friends with the paramedics because you want them to alert you so that the next patient on the CT scanner is your patient. And remember, as I showed to you today, there is no such thing as too late. Somebody presents at 7 or 8 hours, as long as they've got a small core and a large penumbra, we would treat them with IV TPA up to 24 hours currently in a clinical trial, even if they're candidates for thrombectomy also. That's the summary of my first presentation, part of the presentation. And so now for today, I mean, I was asked to talk about thrombolysis 2021. So I'll show you some new data. Some of you may not have seen this, that if you treat early, it makes a huge difference because the clot is soft and the TPA can go in and dissolve that much better. I'll show you how after the first 4.5 hours, multimodal imaging becomes important. I'll show you one slide that currently, the question that is asked of us all the time is, why not tenecteplase? Why TPA and not TNK? So I'll show you data that currently, although we are doing clinical research ourselves also, the TPA is still the preferred treatment. That may change in 2 to 3 years down the road, but currently that's the case. Also, I'll end my presentation with, what are the relative and absolute contraindications? Which wake-up strokes would you treat? What about mild strokes or too severe stroke? And I'll end up with our work with COVID and thrombolysis. So that's what I'll do in the next 25 minutes before I end my presentation. So first of all, speed, I've explained to you earlier, is better. And most of this data is actually coming from the ambulances. And you may recall that original TPA trials, many of you were not born, were done in the early 1990s. We were part of them. Very few patients were within the first 90 minutes. Because of the introduction of the ambulance, we can treat a fairly large number of patients within 1 hour from onset of their symptoms. So the next few slides are prepared especially for you. Have a look at the data and see why speed and early treatment is important. So if you were not to treat somebody with TPA and somebody asked you, in 100 patients, how many patients would make a full recovery? Yeah, so you had 100 patients present to your hospital. Out of those 100, 26 patients, 26% would make a full recovery, right? So if you treated these patients within 4.5 hours, that number increases from 26 to 33, so another 6 patients. Now, if you treated all these 100 patients with TPA within 4 to 0.5 hours from the onset of symptoms, your gain is modest, but it's still there. You've got these 7 patients in addition to the 26 patients, right? Now, instead of 4.5 hours, if you treated these patients within 1.5 hours, this number increases to 48%. So you can see that as you treat them earlier and earlier, your outcome gets better and better. And what's the most recent part? So this was all published information from the NENS trial, but this is what is our data as of this year. So you've gone up now. If you treat them within an hour, let me just minimize this so I can see it myself also. This number has gone up to 60% or more, right? So treating early is clearly beneficial. You've got some gain at 4.5 hours, it improves at 90 minutes, and it improves significantly at 1 hour. So that was my first message to you. Where do we go from here is, this is data from when I first went to Qatar. I was setting up a stroke program for them. So when you set up a stroke program and create awareness in the community, you can see that although the population has not changed for many years, this is where our stroke program started. So you can see suddenly, and we published this, that you were doubling the number of strokes treated with IV TPA every year. And at this point, we published this paper. We showed that actually, if you have a comprehensive program, you can bring your door-to-needle time from 70, 80, 90 minutes to less than 40 minutes. See that? And all this was because we put a comprehensive program in place. So what about beyond 4.5 hours? What do you do in these patients when you give them TPA or TNK? This is where multimodal imaging becomes very, very important. In our center, what will happen is with the same patient who came into the CT scanner, you would now do multimodal imaging because this will help you determine how big is the penumbra, the size of tissue at risk, and how big is the core. For that, you need CT P or CT perfusion imaging. You can also do MR perfusion, but that's just a little more complicated, takes more time. And in most of these patients, you do a CT angio because you want to determine the size and the location of the arterial occlusion. So the bigger the size, the less likely that it'll work, the TPA would work in these patients. And for those, you'll have thrombectomy, which is a presentation that is somebody else will be talking about. So I will not talk about that right now. So here's our imaging center now. I showed you the original part that you'll do a CT. Everyone gets a CTP to find out where the occlusion is. It could be a proximal occlusion or stenosis, and they get CTP. Now, when you look at CTP, there are several ways of doing it. Most of the Siemens scanners would have their own software program. The MyStar, and we use it for research purposes, comes out of Melbourne in Australia. The rapid is what we use mostly these days, and I'll give you examples which will measure your core, which is the irreversible damage in purple, and it'll also show you in green the penumbra, which is the tissue at risk, and this is available on your cell phone. OLIA is also another program that the French offer. So I'm going to be using examples from MyStar or Rapid to explain to you why penumbral imaging is so important beyond 4.5 hours. So these are two patients, as an example. These are from our center when we were using, when we were enrolling into the ESCAPE trial. So the first one here is a patient 71 years old. His onset was 5.5 hours, and his CT scan plain looks very good. He's got an M1 occlusion, and his CTA shows excellent collaterals. So this would be a patient that we'll call a slow progressor. And you can see when you do a MyStar, the green is, which is penumbral tissue, the red is core, and you can see that the core is much smaller than the tissue at risk. This patient was enrolled into the study. He got a stent here. The artery opened up at 7.7 hours, and you can see that there's very little damage in this patient. Here's another patient who comes in at less than 2 hours. Arterial occlusion, you can see there's no collaterals at all. No collaterals at all. There's a big core and very small penumbra. So this patient, although had come in at 2 hours, the artery was opened up, and you can see that within 24 hours, there's a much more tissue damage, there's hemorrhagic infarct, and this patient did not do well. So perfusion imaging not only helps you identify whether there's a tissue at risk, but it will also tell you whether this is a fast progressor or a slow progressor, as is this patient from 2 days ago. Just before I was leaving my hospital, I was on call. So 57-year-old, you can see on the Rapid, which now gives you imaging for the arterial occlusion. So it'll tell you left large vessel occlusion detected. So this patient was 7 hours into the symptoms. Here's the image again on Rapid. You can see that there's some collaterals there. And here's the M1 occlusion. This patient has got some tissue damage, which is approximately 27 mils, but a very large penumbra of more than 100 mils. Now this penumbral tissue, you can further analyze that. If you look at the pattern in here, the Tmax of more than 10, I'm getting a little technical, but it's very important for you to understand these things. The larger your Tmax of more than 10, means this tissue is going to die very quickly. So remember this, large Tmax of more than 10, this tissue is going to die quickly, and you need to go in and open that artery very quickly. This patient was part of our clinical trial called Timeless, which is up to 24 hours, and we're treating them with TNK. And this patient did reasonably well because the vessel opened up. Now compare this patient to another patient in here, in whom the core is tiny. See, all this information you can get with your perfusion images, and their penumbra is massive, huge penumbra, small core. We look at their blood flow patterns, and you can see now that very little Tmax of more than 10. So this is what we'd call a slow progressor. This patient, several hours, the 14 hours, I think, 14 hours after onset, gets a thrombectomy. So here's the occlusion, gets a thrombectomy, and you can see 24 hours later, there is no infarct. All of that core was saved. So the point I'm trying to make is, for the radiologist in your audience at least, that beyond the 4.5 hours, perfusion imaging becomes extremely important for our patients. So let me summarize for you again my second portion of our presentation, which is beyond 4.5 hours, penumbral imaging becomes extremely important. A good quality CT scan is sufficient. Under 4.5 hours, perfusion imaging is very important, and it helps you separate the slow progressors, who will do well if you open the vessel, from fast progressors in patients beyond 4.5 hours. And CT imaging is essential in these patients also. So what about, as I explained to you, I'll have one slide on tenecteplase versus TPA, and the most recent evidence is the following. There is very little difference. So this is meta-analysis of more than 1,500 patients, half of them treated with TNK and half with alteplase or TPA. And you can see that when you look at whether TNK is superior to alteplase, the data at present does not show any superiority. It also does not show any inferiority for aim of better outcome. So until our current trials get completed, it is still 0.9 milligrams per kilogram of TPA as a treatment of choice and not TNK. So finally, I want to go into these special situations. These are very important for you to pay attention to. So the relative and absolute contraindications, whether it's too mild or too severe, the wake-up strokes, and I'll, in the next 10 minutes or so, complete all of these important issues for you today. So first of all, contraindications, right? So here's what the American Heart Association's most recent guidelines are. So if the patient is between 3 and 4.5 hours, they put restrictions. They have to be less than 80 years of age. We ignore that. The NIH-SS has to be less than 25. We ignore this also. This one is important. They should not be taking oral anticoagulants. We agree with this. And their imaging should not show a large stroke, right? So if you look at all that long list of contraindications, you know, these are some of the important ones. Age, they can't be too old. As I said, we ignored this. My third slide here, I'll show you what we do. Severity, we tend to ignore that. I'll talk about the wake-up strokes. You want to make sure that they're not hypoglycemic. Seizures are treatable. You control their blood pressure. And dementia is very subjective. You may, if they're severely demented, you may not treat them. You want to make sure that they're not mimics. Some of you may not know what recrudescence means. This basically means that somebody's had a stroke in the last several months to years, and they have an acute infection, and their symptoms get worse. So it's not a new stroke, but the symptoms from their previous stroke got worse. It's a common, it's like a mimic, basically. So this is your initial group of contraindications. Most of them we ignore. This is a second group. You know, you'll also read recent trauma. Trauma has to be major. The tumor has to be very large. So if they have a meningioma or a slow-growing oligoglioma, we usually treat them. If their aneurysm is small or the aneurysm is clipped or not cause of their bleed, you're totally safe. If they've got a recent MI, you've got to be careful. If they've had previous intracranial hemorrhage, especially if it was subarachnoid hemorrhage, but the aneurysm has been clipped, you're totally safe. If the dissection is in the carotid or the vertebral arteries, you're okay, but you may sometimes find a dissection in the aorta. Those patients, you cannot give TPA. Dual antiplatelets is safe. Anticoagulants, you've got to be sure that they're on it. Most people are supposedly on anticoagulation, but they're not taking it. So if the INR is good in somebody who's taking warfarin, then you go ahead and treat. Low platelet is very dangerous. Active bleeding or recent surgery is dangerous. So to summarize, this is where our important contraindications are. Recent ICH or a large stroke within the previous 6 weeks to 3 months, recent major surgery, if they've got therapeutic anticoagulation or very low platelet counts, very recent trauma, or the use of amphetamine and cocaine. These are major contraindications that you've got to be careful about. So that was the first one. The second one I want to spend some time on is too mild. This is very, very important because you'll see so many patients whose symptoms are too mild. So I want to spend a few minutes on this, or too severe. So let's talk about too mild. First, one of the biggest series that came out recently last year is, this is from the Get to the Guidelines in the US. So it was published recently in Stroke. And this is the data on nearly 180,000 patients. The first point I want to make for you is that mild strokes are very common. So if you look at these patients, the majority, 57, 58% were mild strokes. Mild strokes is a patient whose NIHSS is between 1 and 4, so less than 5. So these are mild strokes. So in these mild strokes, look at this, about half of them got IV TPA. And if you could prove that they had a large vessel occlusion, 10% also had thrombectomy. So first point, mild strokes are very common and about half of them get treated. What about in the Middle East? So we have data we published a couple of years ago, 3 years ago, on progression of symptoms in mild strokes in Qatar. So if you look at this series, a large series, there were 6,300 patients, and of these, nearly half were either ICH, DIAs, or mimics. See, 30% were mimics. So if you exclude those and you focus on those patients, out of these 3,400 who presented in less than 1 hour, you're down to 1,000 patients, about 20% of patients. Of the 20%, there were approximately half the patients whose NIHSS was less than or equal to 5, who presented within 4 hours. So of these, the majority did not get TPA. So 381 did not get TPA, and 125 got TPA. So if you look at these who did not get TPA, the reason for them mostly were either their NIHSS strokes, or reasons for not getting TPA were either low NIHSS or their symptoms improved, right? So what do you do about the patients in whom the symptoms are mild and they have an occlusion either in the MCA or so M1 branch or M2 branch? Here's a paper that just got published recently in JAMA, which showed from France that out of 730 patients, those who progressed are small, it's only 12%. But if they progressed, they had a strong association with poor outcome. So what do we do in our practice? If you have mild symptoms and they're improving, we watch them. If they're mild symptoms and they have an occlusion on MCA, we watch them extremely carefully. We have a very low threshold to go and pull the clot out or give them TPA, depending on the time from onset to when they're seen. So under 4.5 hours, we will frequently treat them with TPA. And if they're more than 4.5 hours, we'll consider thrombectomy in these patients. All right, so that was mild strokes. What about severe strokes? Of course, the severe strokes are common, and these are the kind of things that you worry about. The benefits are uncertain, and the risk of ICH is high, right? But we treat them because if you don't treat them, the outcome is worse than if you treated them. The reason why their symptoms are bad is because they've got poor collaterals. If they have a large occlusion, we still give them TPA, but we think that it's not going to work in most cases, especially if they've got an internal carotid or proximal large MCA occlusion. In these patients, TPA may not work, and if they're more than 4.5 hours, we would consider them candidates for thrombectomies and not give them TPA because of the somewhat higher risk of IV TPA. So mild strokes, we watch them carefully. There's majority of the patients, some of them progress. So multimodal imaging is really important. Large strokes, although the risk of bleeding may be high, the risk of poor outcome is very high also. And so we recommend that they be treated with IV TPA under 4.5 hours and consider thrombectomy, which I won't be talking about today. What about wake-up strokes? So many studies. We were part, in fact, I was in the steering committee for the DIAS trial, the DIAS-2, DIAS-3, DIAS-4. These are with desmetaplase, and they were all negative trials. But we were learning because DIAS was MR mismatch. And then once we got into extend and wake up, extended CT perfusion, I'll show you examples, and everything changed with wake up, which was presented at least 2.5 years ago at the European Stroke meeting in in Stockholm. So what they were using in Wake Up, this is important. So if you have MR that you can use, and the MR has to be a mismatch. So this is a study. The mismatch is the following. On DWI, you see a lesion, but on FLAIR, you don't see a lesion. So here's a bigger one. DWI, you see a lesion, and on FLAIR, you don't see a lesion. This is a mismatch. If somebody comes into your emergency department and you can do an MR and you show this mismatch or this mismatch, you may give them TPA. On the other hand, if they have a match, so here's a small DWI lesion, here is the lesion on the FLAIR, here is DWI, and on FLAIR, this patient would not be a candidate. But this patient does very well, this patient does not do well. In the Wake Up study, these patients were considered for treatment, and you can see that if they were given TPA, there was an absolute improvement of more than 11%. So they do very well. And in our practice also, anyone who comes into an emergency department acutely as a wake-up stroke, we don't use MR, we use CT perfusion. So here's an example of a wake-up stroke with a very large core, a very large penumbra, no core. So very large penumbra, no core. So this patient would definitely be a candidate for IV TPA. And then you would consider a thrombectomy. We'd also consider these patients. So a moderate degree of core, a somewhat larger penumbra, but we will not consider a patient like this. See this very large core, even though the penumbra is larger, anything more than 70 mils of a core, we will not consider them for thrombectomy or for TPA use in the wake-up circumstances. Let me share with you the last part of my presentation, which is our interest with COVID and thrombolysis. We've recently done a meta-analysis on these patients, so we're very, very interested on the interaction between COVID and thrombolysis. In fact, with Mohammed, one of our first papers from Madinah was on the effect of COVID on depression of these patients. And Mohammed and the group had done a very good job. So congratulations to you, Mohammed. It was published in the International Journal of Stroke and has been quoted several times since then. And so the interaction, does acute stroke, so these are the questions, right? There are three questions. Does acute COVID infection increase the risk and severity of stroke? That's your first question. Does COVID pandemic result in changes in stroke incidence? And finally, what is the effect of COVID on the rates of thrombolysis and EVT? So those are three questions I'm going to try to answer for you before I end my presentation in the next few minutes. So firstly, the risk of stroke related to COVID is very low. In large studies, it's been shown that in less than 2% of patients, you can actually show that the stroke may be related to the COVID. It is important because the COVID will either cause damage to the vessels. Remember, the endothelial cells is the primary target for the spike protein in the COVID virus. So it can cause damage to the arterial wall. It also causes cardiac damage, or you can have venous thrombosis that can go through a PFO. So these are the mechanisms, but the incidence is very low. What is actually very interesting, and we've studied this in a meta-analysis now, is that during the COVID infection, the rates of strokes decreased significantly, and most of these were mild strokes and stroke mimics. And we were never sure what caused this decrease in admission during the pandemic. And there are lots of theories around that. Perhaps the incidence of stroke and MI decreased because of improving air and decrease in pollution. It was also related to decreased physical mobility and the decrease in other viral infections, etc. But I'll show you the data in Qatar, which is very interesting. That in Qatar, this is something we published recently, is that as the pandemic hit them, which was in March, you can see that the biggest decline was in stroke mimics. The stroke mimics went down from 108 in February to only 27 in April and May. And as the pandemic started improving, these numbers started to get better again. The acute large ischemic strokes also decreased. This decrease was about 20 to 30%. So we went ahead and did a meta-analysis. So here's the meta-analysis of countries in Asia, in Europe, and in North America. And we found that if you put all these studies together, there was an approximately 30% decrease in the incidence of stroke during the pandemic. There was also some decrease, marginal decrease. It's about 7 to 17% in intervention EVT in these patients, but their thrombolysis rates did not change. So here's thrombolysis rates. So although there was a decrease in the number of strokes, we believe they were mostly mild strokes, TIAs, and mimics. Their IVTPA rates did not change. All right, my final slide is here. This is fascinating stuff. This is something we are now studying. That if you look at the first, this is in the US, this is the first increase of the pandemic. So this is the first surge last year. This is the second surge. And this is the third surge, which was the biggest surge, which was during the winter months. And if you look at the stroke incidence, in the first surge, the numbers in the US also decreased significantly. See that? But during the second surge and third surge, we did not see the decrease in the numbers of strokes. I don't know why. No one knows. And we are really curious to find out, and we are studying this right now, that why did the numbers of strokes decrease in the first surge of the pandemic, which was mild, and in the most severe third surge, there was no changes in here. Something to think about. If anyone has good ideas, send them to me. So here's my conclusion. I hope I've convinced you that prevention of complications is very important. It's a multidisciplinary approach, and this can be best done in a stroke unit, and these patients should be transferred to the stroke unit as soon as possible. I've also shown you, so the new data is that thrombolysis is highly effective in the first hour or so. And if you can see, here's my rapid, so as I'm talking to you, we just had a stroke, which is showing me where the occlusion is. And so time is very important in these patients. I didn't make this up. It just happened as I was making this presentation. I've also, I hope, convinced you that multimodal imaging is essential to figure out how much the TPA is going to work in these patients. So I said 40 minutes, and I am done. Thank you for your attention.
Thank you so much, Professor Dr. Ashfaq, for that conclusive, outstanding presentation. And it was an unusual presentation about thrombolysis. And you touch big area of study regarding extension of time based in different brain imaging modalities. I have a question for myself. To what extent can I use CT perfusion regarding thrombolysis, not thrombectomy? If I go beyond the 4.5 hours, till what extent? 6 hours, 12 hours, to what extent?
That is such a good question, Mohammed. If your plain CT scan looks good, so if somebody comes in at 3 days, so I'm going to make it look even more controversial. So you've had a patient who comes in at 3 days with an NIH, so a big stroke, and your CT scan looks beautiful, looks pristine. You can't see any damage at all. In that patient also, you do CT perfusion. If you can show that the core is small and their penumbra is large, that patient would do very well if you take the clot out. If you want to have a reference for that, in JAMA, there's a paper last year from Korea, and they South Korea, they went up to 10 days. So your question is a good one. So if your CT scan looks to show a big infarct, then you don't do anything. But if the CT scan looks good, at definitely up to 24 hours in most cases, but sometimes you can go up to 2-3 days or longer also.
Looks good to what is mean? Good, no large infarction or radioclinical dissociation?
Good is when you take your scan and review it with your radiologist, and the radiologist tells you that the aspect score is 7 or more. So 7, 8, 9, that's good.
Okay. So second question, we also Professor Dr. Ashfaq, if we don't have CT perfusion, could we depend on extension of the window based on CT angiography, the 3 phases regarding collaterals beyond 4.5 hours, or it doesn't make us compensate the CT perfusion?
That's a very good question. I am going to be, I'm going to ask you, whoever put that question, to go to your radiologist and beat them up. They should have CT perfusion. I think it's really, really important. There are some centers, my colleagues to the south in Calgary, they promote that a 3-phase CT is sufficient. I don't believe so. I think you need to be every single study that has shown good results, whether it's Dawn, whether it's Diffuse, they've all used CT perfusion. So if you're not going to use CT perfusion, you've got to be extremely careful when you go beyond 4.5 hours. That's my opinion. Of course, you know, we can have a debate about that, or somebody may not agree with me.
Okay. We have also a comment from one of our audience, also regarding your last slide. He says that in the first pandemic, we found a decrease in stroke cases, but the wave was also minimal compared to the third wave, where the cases didn't decrease nor increase.
Well, ask this person why. That's what I want to know. I can't understand that. It just is eating me. I mean, I want to know the answer for this, and we can't figure it out. But it's a very nice observation, isn't it?
Okay. Thank you so much for that informative presentation, and hope to meet you again in another scientific events. Now we have Professor Dr. Ahmed Bassiouni, Professor of Neurology and Neurovascular Intervention at Ain Shams University, has joined us. Professor Dr. Ahmed Bassiouni will talk us into a journey regarding endovascular intervention in acute stroke. Hope to find your expectation regarding that expecting to be valuable, more precious, informative presentation. Welcome, Professor Dr. Ahmed, and you can start.
Thank you, Muhammad, so much. Dr. Muhammad, thank you so much for the invitation, and thank you for the Saudi German hospital team for such an invitation. I don't know about whether my screen is okay now or.
Yes, yeah, the screen is okay. Could you start sliding the screen?
Can you see it now, Muhammad?
Yes, I see it. Could you start sliding? Because I just have.
It's obvious now.
Yes, it's obvious now. It's clear. Yes, it's clear.
So it's time to talk about the endovascular treatment of acute ischemic stroke. And as you know, I would like to be somehow practical in this presentation. I will pass very rapidly with the guidelines, but I would like to talk about the difficult situations that we are facing because it's not always a straightforward procedure. Let's talk about the stroke burden in our region. As you know, if we talk about Egypt and Saudi Arabia, for example, we are facing like 220,000 new stroke cases per year in Egypt, and like 64,000 cases, new cases per year in the Saudi Arabia. we are in a hot area regarding the incidence of new stroke cases per year in our region. All of us know now about the guidelines since 2015 that any patient presented with a pre-stroke MRI stroke of 0 to 1 and having an occlusion in the internal carotid artery or the mid-cerebral artery segment M1 occlusion with an age group more than 18 years, and then HSS score more than 6, aspect scores more than 6, so the treatment should be initiated with groin puncture within 6 hours of symptom onset. This is a class 1A recommendation. This is the ideal practice which no one can now. We should all do this, and we should all make this the practice in our region. Unfortunately, it's now until now there are many places which are not having the capacity, whether with the human resources or the instruments to do this. At least in Egypt, I know the situation in Saudi Arabia is much better than Egypt in this situation. But the process is growing now in Egypt on a larger scale. Why middle cerebral artery occlusion? Simply because if we have a look here, the middle cerebral artery is outside the circle of Willis. And the middle cerebral artery is giving a large area of the brain. Almost all the hemisphere is being given by the middle cerebral artery, and there is very important area which are being supplied by the middle cerebral artery, like the motor area, the speech areas, especially by the superior division of the middle cerebral artery. So the sudden occlusion of the middle cerebral artery is catastrophic, as well as the basal ganglia. So the sudden occlusion of the middle cerebral artery or the internal carotid artery with the middle cerebral artery and anterior cerebral artery, it's a catastrophe which happens to the patient and should be saved within minutes or as soon as possible. I will ask some questions and have some answers. Some I have answers, some I don't have answers. The question number 1, until when we can do the thrombectomy, and the question number 2, how to assess patients for the benefit of the thrombectomy. As we know that time is brain, but each brain has its own time. So this is completely, of course, dependable on the collaterals. Because when we have an occlusion in the middle cerebral artery, like this is the area what we call the core infarction. But we are having those leptomeningeal collaterals between the ACE and MCA and the PCA and ACE and MCA. These collaterals is the key or the secret about how much the patient will maintain the penumbra, the area which is salvageable in the brain, and as much as we can, we should intervene in such a patient to save this hemisphere. These collaterals, generally speaking, are very good and robust in young people. In children, sometimes they reach like 1 millimeter in diameter. And by aging, they became very weak. And this is why the outcome stroke with the age is much worse than in younger people. The clinical assessment, as we all know, I don't want to waste time in such scales. The NIHSS scale, I think every neurologist now, everyone who is dealing with stroke, whether neurologist, whether emergency medicine, whether in ICU, can do the NIHSS score. And the second step, I will give some hints about the imaging for such patients. Number 1, any patient which come in the emergency, we do the aspect score, the initial CT, in which there is 10 areas which represent the supply of the middle cerebral artery. There are about 7 areas in the ganglionic level, the caudate, the lentiform, the internal capsule, the insula, and in front of the Silvian Fisher M1 segment, just behind the M2 segment, and behind the M3 segment. And in the supraganglionic levels, there is another 3 areas. If in the CT, we find that the aspect score is less than 6, which means like there is 5 areas from this have hypodensity, then the patient most probably is having a massive infarction and a severe collateral failure, and there is no need to do the intervention, because the intervention in these patients may be even more harmful, not just a failure. This is the example of the aspect score as we were talking about now. Then if the patient, if I'm in doubt or the patient passes the 6 hours, we do the MRI, the diffusion weighted best parameter, the best parameter for the volume infarct. Any diffusion weighting more than 70 cc is a major predictor of bad outcome, which means there is a large infarction in the brain. The second important parameter which we are using in the MRI, the flare, of course. Why? Because in the flare give us very important information. If we see the infarction in the flare with the same density like here with the diffusion, this means that there is a long time in the patient, more than 6 hours time happen, so that I can see an infarction which is very evident like the diffusion in such a patient. If I see the infarction, the diffusion, and I don't see it in the flare, this means that this part is still not infarcted. And it's also indicator of the time that now we are in less than 3 hours from the onset. If I see the infarction obvious in the diffusion, and like we say in the gray zone in the flare, this means that the patient is in the window of 3 to 6 hours. This is very important in our decision, especially in the patients with wake-up stroke. For me, for myself, any patient with wake-up stroke, I prefer to do for him MRI diffusion, flare, and see if there is a mismatch. If the patient like this with an M1 occlusion, and the flare is normal, and here we can see the lip to meningeal collaterals which are very evident in the flare. I hurry up and do thrombectomy for such a patient, because this patient would be completely saved in such a situation. If the patient is like this, I will do also a mechanical thrombectomy, but I'm not expecting a very good outcome if I succeeded to open the occluded artery. If I see the patient the diffusion like the flare, this means that these areas are already infarcted. So the diffusion flare mismatch is something which is very, very important in the decision making for us. Also, we continue with the MRA. In the MRA, I see 2 important things, or 3 important things. Number 1, I see the site of occlusion exactly. Number 2, I see the anatomy, because this is very important, tortuous anatomy. This helps me to prepare myself with the instruments I need to be ready in doing such a patient. And of course, I see the collaterals. If you see like a patient like this, very, very good collaterals on the left side when it's compared to the right side. This is a patient without seeing his MRI diffusion and flare. I will go immediately to do such a patient, because I am expecting very much to have good outcome from such a patient. The other parameters are the perfusion parameters. There is a lot of perfusion parameters, but I think that the most important is the mean transient time. It's the time in which the blood goes from the arterial phase to the venous phase. It represents the time the blood is spending in the collateral phase to oxygenate the brain, which is deprived from oxygen. If we am having, this is the most important parameter. If I'm having a mean transient time more than 7 seconds or more than 1.5 the time of the normal side, this means that we are having a core infarction, and the tissue of the brain is not salvageable in such a situation. We can see this in such a patient. Here, the mean transient time is more than 1.5 more than the other side, or the mean transient time, the absolute value more than 7 seconds. And you can see with the MRE, there is no collaterals in such a situation, which means that this patient, all of his hemisphere is now a core infarction, it's not a penumbra, and that this patient will not benefit from the interference. Sorry. Again, the CT angio is a very, very, very important parameter in the assessment of the timing. The question you were asking, Muhammad, about to what extent or what is the extent of the time to do intervention in a patient with an immediate cerebral artery occlusion. We can see like we have an early arterial phase, mid arterial phase, and late arterial phase in the multiphasic CT angio. This is a patient with M1 occlusion, is having very good collaterals in the, sorry. Is having very good collaterals in the early arterial phase, and still in the mid arterial phase. And if we see the late arterial phase, we are having the collaterals are still there in the site of the occlusion. The middle cerebral artery collaterals, the leptomeningeal collaterals, they are very nice collaterals in the late arterial phase. This is a patient with an extremely good outcome. This is the patient, which means that his perfusion parameters are very encouraging to intervene. This is another example of a patient with also middle cerebral artery occlusion. We are having a good collaterals, okay, during the early arterial phase, but the mid arterial phase, there is the collaterals is trying to keep the blood as much as possible to oxygenate the brain tissue. Then they are fading in the late arterial phase. And we can compare this with the poor collaterals in such a situation, M1 occlusion. From the beginning, from the early arterial phase, you can compare this with this one. From the early arterial phase, there is no collaterals, which means that this tissue is all core infarction, and there is no way to intervene in such a patient, even if he came in the first hour from the presentation. This is a patient which I can intervene, even if you are coming after 2 days or 3 days with M1 occlusion. But this is a patient which I will not intervene even if he come after 30 minutes. So the timing is not by the minute as we are thinking always. Although in the 2018 we have the two famous trial, the DAWN and the DIFFUSE trial. We know in the DIFFUSE trial it's a great 1A also recommendation that we can do mechanical thrombectomy to the patient within 16 hours if he is having a good perfusion parameters. Then came the DAWN trial until 24 hours. But I think that our way of thinking will change with time. The CT, multiphasic CT angio will play, and or the MRA also with the MRI diffusion flare mismatch will play a very important role in the decision making about which patient will benefit really from doing mechanical thrombectomy. Some patient could be saved until 48 hours. Some patient after 1 hour will have a severe collateral failure, and he will not benefit either from thrombolysis or the mechanical thrombectomy. In the view of such recommendations after the DAWN and DIFFUSE trial, I always like to show this example from my practice. This is a patient about 2 patients who were presented, this one and this one, who were presented in the same hour in one of the hospitals in our university hospital. One with, as you see, basal ganglionic infarction, and his M1 occlusion was occluded, and he was presented after 16 hours. Both patients were presented after 16 hours. This patient, we went and we did mechanical thrombectomy, and the patient was markedly improved because as we see here, the infarction was small. And when we did a good recanalization for the middle cerebral artery, the patient was having a very good outcome. And the same time, almost the same patient with a basal ganglionic infarction, with internal carotid artery occlusion here, with middle cerebral artery occlusion, what we call tandem occlusion. and the patient was presented also after 16 hours, maybe in a better clinical situation than the previous patient, and his family refused to do the mechanical thrombectomy, and this was the result on the next day, malignant MC infarction with herniation, and of course the patient died within 48 hours. So selection of the patient based on the MRI diffusion flare, MRA, or the multi-physic CT will play an important role regardless of the timing of intervention. Question number 3, which is a dilemma in my opinion. What about MC occlusion with low NIHs? In such a patient, there is no clear recommendation. All the recommendations are 2B recommendation. Although the benefits are uncertain, the use of mechanical thrombectomy with stent retrievers may be reasonable with acute ischemic stroke in whom treatment can be initiated within 6 hours of symptom onset, and who have pre-stroke MRS plus more than one aspect less than 6, NIH less than 6. And I think this dilemma is important in our region because I can explain this because we have many cases of intracranial atherosclerotic disease. So that in such patients, we find that many people are having underlying intracranial stenosis, and when they have acute occlusion on top of chronic stenosis, the patients are not having a massive stroke. But we cannot guarantee this. So what we do in such situations that we leave our resident beside the patient, especially by night, because the patient maybe if you are having during sleep a low blood pressure, the manifestation can increase and the patient can enter into a total MC occlusion or malignant MC infarction. So this patient needs a very, very strict observation. In my school, in Ain Shams University School, we don't intervene. We wait and see if the patient at any time develops some new symptoms. We immediately go and intervene in such a patient and do the mechanical thrombectomy. Question number 3, what about the IV thrombolysis and thrombectomy? I think that this debate is very clear. Once the patient is presented in the time for TPE, he should receive the TPE. The TPE, in my experience, make the mechanical thrombectomy procedure is much easier because it helps to us in the procedure, whether by aspiration or by stent retriever. This helps us a lot. In patients under consideration for mechanical thrombectomy, observation after IV TPA, unfortunately, we still see this practice. Some physicians give the patient TPA and wait for the response. This is not the practice. The practice, the ideal practice, the patient on the CT takes the TPE, we continue the CT multi-slice physics CT or whatever the MRI diffusion flare MRA. And we go, once we confirm there's an MC occlusion and the patient is meeting the criteria, we go immediately to do the mechanical thrombectomy. But we are facing some situations like the 2 examples I will show now. One of them that most of the patients we are dealing with are the patients with are having an AF, it's an embolic source from the heart. This patient, which is having a small basal ganglia infarction, MCA occlusion, and we did the mechanical thrombectomy for the M1, as you see here, and we succeeded to open the middle cerebral artery. During the procedure, I found that there is an A1 occlusion, anterior cerebral artery occlusion. I found that this, because we did inadvertent thromboembolism from the previous thrombus. So we went and we opened the middle cerebral artery and we finished the procedure successfully. The right middle cerebral artery is good, the anterior cerebral arteries are good, and the left middle cerebral artery is good. And the patient, next day, we found this large infarction in the left middle cerebral artery after we finished the procedure. Sometimes the TPA prevents us, as you know, the TPA prevents us from giving anticoagulation. to prevent against further cardioembolic embolization. So it's a dilemma. What about giving the patient TPA if he is having AF? The patient can present with another MC occlusion during night after doing the previous procedure. The second problem when we are giving the patient TPA during mechanical thrombectomy, that sometimes you are like here. This is an iatrogenic dissection, the internal carotid artery, during our attempt to do the mechanical thrombectomy in the patient which is having M1 occlusion. So we went and we put a stent. As you all know, if the stent is a foreign metallic body, which needs that you will give antiplatelets in order not to have a thrombus on the surface of the stent. It's in such a situation, it's a dilemma. After giving TPA, you will give the patient a massive antiplatelets to keep the artery open with the stent. Sometimes we cannot give this, and sometimes if we cannot give the antiplatelets, the patient will have a stent occlusion. If I give antiplatelet, we are facing a massive intracranial hemorrhage. In such a situations, it's a dilemma. If the patient is already receiving TPA during mechanical thrombectomy, if he is presented in the window of IV thrombolysis. Question number 5, what is beyond M1 occlusion? And this is an area of research now. What should we do? Again, looking at the guidelines, although the benefits are uncertain, the use of mechanical thrombectomy stent retriever may be useful or reasonable for carefully selected patients with acute ischemic stroke with M2 occlusion or M3 occlusion. In my practice, what we are doing now mechanical thrombectomy for patients with superior division only MC occlusion. Because I don't want to say this, but the inferior division of the middle cerebral artery is much less important than the superior division. The superior division is giving the motor area and is giving the speech areas, whether the Broca's or the Vernix area. So same in the superior division, it deserves to do mechanical thrombectomy for patients with superior division MC occlusion. If they are having M2 occlusion, if I'm having a patient with inferior division in my practice, I leave him personally, but I don't do anything. Question number 6, what about some technical issues in the procedure? It's also the war of the companies to do stent retriever. As we we do mechanical thrombectomy either by doing a stent, which is like a net or the snare, which catch the thrombus and get it out, or by going to these catheters, which is very kinky and is having large bore for aspiration and aspirate the thrombus. This is also it's not a dilemma, the rule is to use whatever you feel comfortable with, and no one of them is having 100% efficacy. So in most of the cases we are using trying with one technique, then using the other, or trying both techniques from the beginning. Do whatever you feel comfortable with, and do whatever you are used to use. But you should know both techniques, because sometimes or many times you fail with one technique, and you are obliged to use the other technique. Many trials are going to prove the superiority of one technique over the other. But in my practice, as I told you, I think you should handle both techniques. And sometimes we are using both techniques in the same setting in order to maximize the efficacy of our technique, especially with the patients which are presented late to us with a stroke. Some examples like this, patient with MC occlusion. We tried to use the stent retriever. We opened the other technical issue that we should try the best to open every artery. In a patient like this, we succeeded to open the superior division. Then we went with another stent to open the inferior division of the patient. Another issue, a patient with MC occlusion, we tried stent retriever more than one time, it failed in such a patient. After doing stent retriever. We did the aspiration. This is the catheter for the aspiration, and we succeeded to aspirate the thrombus and recanalize the artery completely. The question number 7, which is very important, what about the intra-arterial pharmacological agents? This is not about the thrombolytic. This is not about the TPA. This is about using the antiplatelets. So it's obvious so that we does not have enough data about giving intra-arterial agrastat, which is the glycoprotein 2B3 antagonist, in order to distribute the thrombus. We use this actually when we are doing another elective cases like aneurysm or AVM, and the patient is having a thrombus during the procedure, which happens sometimes. So we are injecting the TPA intra-arterial because this is the timing of platelet adhesion. So if we succeeded to discover this early and give the patient intra-arterial antiplatelets, it dissolutes the thrombus and prevents the platelet adhesion and makes good recanalization. The only thing that we are using intra-arterial pharmacological agents, antiplatelets by name, if I am obliged to put a stent, and the patient is not receiving TPA, and the patient is not having a large core infarction, because once you would use intra-arterial antiplatelets and the patient is having large core infarction, you should expect massive hemorrhage. And if the patient is have received TPA and you give intra-arterial antiplatelets, the patient will have again massive hemorrhage. So we should be very cautious about using intra-arterial antiplatelets, especially that we does not have enough clinical trials about such a practice. The question number 8 about anesthesia. Some physicians like to do the procedure with anesthesia like me. Some patients does not like to do the procedure with anesthesia. And the core thing is about the blood pressure. If you can do and you have a trained anesthesia team to do the anesthesia for the patient, which is much more safe because the patient is usually agitated, and this can cause many complications and can delay the recanalization. If you can do this without hypotension, because as we know that the blood pressure is the main defense mechanism the brain is taking to overcome the acute thrombosis. If you can do this without hypotension, do it. If you are subjected to severe hypotension, try to avoid anesthesia. This is what we are doing. We do the procedures with anesthesia, and we are trying always to instruct the anesthesiologist that the patient should not have a hypotension. And once the patient we succeeded to do the recanalization, we immediately and strictly ask the anesthesia team to lower the blood pressure of the patient to the normal, to avoid the reperfusion injury and in order the patient does not enter into reperfusion hemorrhage. What is missing? There are some questions which are a dilemma, still dilemma. One of them is the tandem lesions. Tandem lesion, which means that the patient is having an extracranial carotid and intracranial occlusion together with each other. Number 2, the underlying intracranial stenosis, as we spoke from minutes, which is very common in our region, we and the Far East region. And number 3, about the acute dissection. Regarding the tandem occlusion, this holds up to the issue of the carotid revascularization. And we have two items about the carotid revascularization. Whether carotid revascularization with intracranial clot, like such a patient, the patient is having carotid occlusion and middle cerebral artery occlusion. So in such a case, we went and do mechanical thrombectomy to open the middle cerebral artery. Then we did a stent to the extracranial carotid. And there are two schools, school are doing now the extracranial stent, and another school which delay the extracranial stent to another session in order not to be obliged, as we say, from some moments to give the patient antiplatelet to keep the stent patent. This is about the carotid revascularization with intracranial clot. another carotid revascularization without intracranial fluid. And this carries us back to an entity of stroke, which are the hemodynamic strokes. This is why every physician should know now about the anatomy, about the vascular anatomy by heart, as we say. In such a patient which is having frequent strokes and the frequent and progressive strokes within 1 day, and we did repeated MRI every time we find a new stroke in such a patient. If we analyze such a patient, we find that the patient is having an internal carotid artery occlusion like here, but the midcerebral artery is patent. This is the midcerebral artery on the left side. Here, the internal carotid artery is occluded. This is the other side. The midcerebral artery is still patent. Why the patient is having a stroke? Everything because if every time and every few hours, because the patient simply does not have good circular fluid. So this is the A1 segment of the left side, but it's absent, and this is normal variant. So the patient does not have a good cross filling from the right side to the left side, and this left MC is thriving for blood from a very poor collateral. So every time the patient is having some hypertension, he will enter into a stroke. So such a patient should have an immediate revascularization of the internal carotid artery in order to get a good forward flow from our antegrade flow from such occluded carotid. This example is very important because we always forget about the hemodynamic stroke. The hemodynamic stroke is a very, very, very important entity in the patient presented with in the acute window, not just a patient with the regular MC occlusion, and we are going and open the MC. Sometimes many people which see such an MRA say it's normal, the midcerebral artery is working. Do not do anything for the patient. If he is in the window, give him TPE. If afterwards, give him just conservative measurements, and they do not focus on the perfusion of such a patient. This is the perfusion parameter of such a patient. There is a severe perfusion deficit on the left side regarding when comparing it with the right side. And this is why the intervention was mandatory and extremely successful in such a patient who returns normal immediately after doing the procedure. About the MCE, about the patient with underlying intracranial stenosis, which is very common in our region, then the patient is having an acute clot on top of chronic occlusion. This is why sometimes we see some patients, as we spoke from some minutes ago, we are having MC occlusion without very high NIH score. This is a patient who was presented to our department with an MCE territory infarction and M1 occlusion, like we see here, and an NIH which is 9 to 10, which was borderline. We went and we did the mechanical thrombectomy successfully. And if we see here, after doing the thrombectomy, you can see these shadows. These shadows it's an old plaque doing the MC stenosis. You can see that this artery is not normal. And also, if we see the other side in the MRE, you will find this focal lesion in the other midcerebral artery, which means that the patient is having an advanced intracranial atherosclerotic disease. So after doing the thrombectomy, we will find that the artery will occlude again because this stent which we are using in the thrombectomy is doing friction to the older plaque, releasing the platelet content, and with the platelet adhesion factors, a new thrombus will accumulate and occlude the artery. So in such a situation, we just place the stent and leave it in place and giving the patient antiplatelet in order that the stent will not occlude, and waited for like 15 minutes to make sure that the artery will not occlude and the stent is patent. And this is the follow-up of the patient. This is the shadow of the stent, and the hemisphere is completely normal. And the patient returned even to the baseline, even the basal ganglia infarction. We were seeing in the MRI is now very minimal shadow. The patient returned to the baseline. What about the dissection? The dissection is common in young people. There is a flap between the median and metatia. In such a situation, there is a false human. The false human can shower, as we all know, or doing hemodynamic effect. So in such a patients, it's preferably to put the stent to seal this occlusion, this tear, and prevent further embolization through the stress of the stent, and keeping the patient antiplated. And in such a situation, it's usually is having a good outcome. The last issue, I think that the next, this is almost my last slide, the next years will show a complete change of practice, because we are advancing to the era of having the machines which will allow us to do what we call direct to the angioscope. The new coming machines in the world, the new angio machine will do three things. In fact, they will do very good CT quality CT, right, which will allow us from the initially to know if this is a hemorrhage or infarction. When the patient is presented with stroke and there is no hemorrhage, we will give him a TPA. The same machine will do a multi-phasic CT. This is a CT of an angio, so it's not a CT of a CT machine. And the new machine will do the multi-phasic CT to do a CT perfusion. They will be connected to some sort of the new softwares like the rapid software or whatever, so that it can give us the perfusion parameters for the patient on the spot, on the angio machine. Once we are having such a situation, patient with perfusion deficit with MC occlusion, we will go immediately and do the thrombectomy after he received the initial bolus of the CPA. And this will allow also to do a reperfusion again after doing the mechanical thrombectomy to assess the change of the parameters of the perfusion of the brain. I think this will be the gold standard within a couple of years, or 2 to 3 years. But still, of course, these machines will be expensive, at least in the beginning. But they will make a huge change in the practice in the field of stroke. So there is a lot of unanswered questions are still there, and the vascular treatment of acute stroke needs a lot of future research to answer these questions. And thank you again, for the Saudi German Hospital, and thank you for Dr. Muhammad for such an invitation. If there is any questions, thank you. Hello.
Thank you, Dr. Ahmed. I think Dr. Fuad.
Thank you so much, dear Professor Dr. Ahmed Bassiouni. And it was really touching our daily clinical practice. Really, I got a lot of information, so that interesting presentation. And for our audience, if they wanted to ask any questions for Professor Dr. Ahmed Bassiouni, they can hit the question answer icon. And at the end of our session, we will answer that questions. Many thanks to you, Professor Dr. Ahmed, for that valuable, precious presentation.
Thank you.
So could you stop sharing in order to be able to share my presentation?
Thank you. Thank you.
Welcome. I'm going to present to you my presentation about code stroke, logistics and the code stroke team. That is an important issue for all people and all specialties involved in stroke care. We will go through a journey about this issue. Mr. Ala, is it clear to you?
No, till now, nothing shared.
Nothing. Okay. Is it clear now?
Yes, yes, doctor, yes. Please put it full screen.
Okay. Is it right now?
Yes, Dr. Muhammad, proceed, please.
Okay, so I will start. Our presentation today about code stroke. This is me, Dr. Mohammed Fouad, Director of Stroke Program at Saudi General Hospital, Madinah. I'm fellow of European Board of Neurology. So the first questions to all our health personnel involved in stroke care. What is the importance of code stroke? Stroke care is a multidisciplinary process, and the time is crucial factor in that process. Establishing a stroke team involving all specialties other than neurologists who are involved in stroke care with well-designed tasks and work in harmony is very essential. Providing suitable logistics for that team to achieve their tasks in the stroke process is necessary. All that previous need a uniform alertness methods in order to guarantee providing best care in best time, and this is the importance of code stroke. Who are stroke team members? Stroke team, this is a process of multidisciplinary team involving a lot of medical specialties involving in stroke care, starting from ER till rehabilitation and follow-up in outpatient clinic. We have stroke nurses in emergency department and stroke unit and wards, stroke nurse educator, emergency department physician, neurology doctors, radiology doctors and technician, neurovascular and neurointervention specialists, neurosurgery doctor, anesthesia doctors, ICU doctors, lab doctors and technician, physiotherapists and rehabilitation services, nutritionist, pharmacists, and also social care worker. So what is the process chain for a patient to present to the hospital with a stroke? Understanding the process chain and logistics will enable all health team involved in stroke care in order to have comprehensive and general idea about the pathway of stroke patients in the hospital. First, the patient presented to emergency department triage or in patient stroke, as we may have stroke patients from inside the hospital. Immediately, the patients will be screened for signs and symptoms of stroke according to the protocol, which is usually simple, fast, facial asymmetry, arm weakness, speech abnormality, and time. If the patient having such a simple screening, if yes, we will ask us a question: is the time is less than 24 hours from the onset of stroke symptoms? If yes, we will immediately activate code stroke. After confirming the symptoms with emergency department doctor, ward doctor, or stroke nurse in emergency department or ward, there should be less than 10 minutes from door of arrival till first medical contact. Then proceed to nursing protocol. The nurse immediately will proceed to ABCD screening and immediately put two wide bore intravenous access in the upper limb. And if low flow oxygen saturation less than 94% oxygen saturation, we will put the patient on low flow oxygen 2 to 3 liters per minute. We will immediately make random blood sugar to the patient without waiting any order, as hypoglycemia may mimic stroke symptoms, and the patient may be in hypoglycemia, and then we will go for lab sampling. Immediately, as all the hospital alerted through code stroke, we will arrange rapid transfer to brain imaging room and to have CT brain, basically in order to exclude presence of intercerebral hemorrhage. And we may use CT angiography if the possible mechanical thrombectomy service available in the hospital or nearby area. And also we may use CT perfusion in order to adjust our window and the beneficiary of the patient from mechanical thrombectomy. as mentioned in the presentation of Professor Dr. Ashfaq and Professor Dr. Ahmed Bassouli. But as a standard, in case of stroke onset of symptoms more than 6 hours and less than 24 hours, according to the protocol, we will go to CT perfusion, but studies and literatures extended that it may reach till 72 hours and till 10 days, as Dr. Ashfaq advised us. While MRI, MRA should be asked in limited conditions according to the neurology decision, as we see in the previous lecture of Professor Dr. Ahmed Bassouli. Then process of basic brain imaging, CT brain, CT angio should be in time less than 25 minutes of door to arrival and first medical contact. Interpretation of the brain imaging by neurologist and radiologist, who should be present within 15 minutes of stroke code activation or immediately informing about presence of stroke patients. That process should be less than 45 minutes of door arrival or first medical contact, and then decision making if it is hemorrhagic stroke or ischemic stroke. If it is hemorrhagic stroke, we will go through hemorrhagic stroke protocol, which may be need neurosurgery intervention or just conservative treatment according to the evaluation between neurologist and neurosurgeon. If it is ischemic stroke, and we will proceed to either of the following protocols. We may have a patient with acute ischemic stroke excluded from intravenous thrombolytic therapy and mechanical thrombectomy protocol. At that time, we will arrange transfer of the patient to stroke unit and will start preventive measures and complete stroke workup regarding the investigations. We may have another scenario, acute ischemic stroke patient excluding from intravenous thrombolytic therapy and candidate for mechanical thrombectomy based on neurological evaluation and brain imaging modality. At the time, arrangement with neurovascular interventionist on duty, and if the service is available, start arrangements according to the protocol. We may have another scenario, acute ischemic stroke, candidate for intravenous thrombolytic therapy and excluded from mechanical thrombectomy. At the time, intravenous thrombolytic therapy consent obtained after revising inclusion-exclusion criteria and start intravenous thrombolytic therapy according to protocol, and that process should be in time less than 60 minutes from door to arrival or first medical contact. This is a time of performance, but we may do beyond 60 minutes as long as the patient is still in time window, but this is a performance indicator. Then the patient will be arranged to transfer to stroke unit and complete his plan of management. We may have another scenario, acute ischemic stroke patient who candidate for both intravenous thrombolytic therapy and mechanical thrombectomy. At that time, arrangements with neurovascular interventionist, if service is available. We will start intravenous thrombolytic therapy without any delay till case lab ready and still infused till time of going puncture and then stop. With all protocols of arrangements to transfer to stroke unit and to complete the plan of management, and after being stable, he will pass the critical phase to be transferred to ward, and after a period of time, according to each patient, the patient will be discharged either to home rehabilitation service or may be transferred to another social care institutions and will be followed up in outpatient clinic. But all patients are recommended to be admitted in a stroke unit, as in a stroke unit will be best monitored and have best training health personnel, and the patient outcome in a lot of literature found that stroke units improve the functional outcome of the patient regarding the stroke care other than other areas in the hospital. All patients and their caregiver to receive the patient education resources about medication, follow-up, nutrition, lifestyle modification, rehabilitation plan, alarming the signs of their conditions, and how to access to emergency if there is any deterioration or new related events, and regular follow-up in preventive stroke clinic. So, to whom could stroke alert and the duties for stroke team members. Code stroke will alert all team members on duty. We'll start with stroke nurses in emergency department and ward. The nurse will do rapid assessment of stroke symptoms in emergency department or in ward room. With elaboration of time onset, if less than 24 hours, immediately call emergency department physician or ward doctor and confirm the symptoms and time, then code stroke activated. Also, it will perform intravenous RTPA checklist protocol before and during or checklist protocol, and the process of monitoring and follow-up during and after intravenous RTPA if there is any complication, and the frequency of monitoring of vital signs, neurological status, general condition, and possible complication. And she will assure filling the checklist to monitor code stroke process in order to make the briefing about code stroke process regarding performance indicator. Also, emergency department physician, they can activate code stroke and call neurology doctor on duty and assure screening regarding airway, breathing, circulation, or disability. They will order further lab sampling regarding CBC, urea, creatinine, random blood sugar, bleeding profile, electrolytes. But it is important to remember that we will not delay the patient process regarding thrombolytic therapy or mechanical thrombectomy without two basic investigation, which is CT brain and random blood sugar. The other investigation regarding bleeding profile, creatinine, will be based if the patient has history of bleeding disorder or irregular use of anticoagulants or have history of renal impairment. At such time, you can delay decision until the results of such lab. But if the patient has no past history regarding renal impairment or bleeding disorder or not on anticoagulation therapy or large dose antiplatelet, we can proceed directly to our decisions regarding TBA or mechanical thrombectomy without waiting the results of such lab. Then ER doctor will arrange to transfer the patient as soon as possible to CT room even before lab sampling and to be sampling there in CT room. And the system is good and working well. If we shorten the duration from time of presentation of the patient to emergency department and transfer to CT, if that duration is shorter, this means that the system is working well. Also, emergency department will order ECG, but not to delay transfer to the patient to CT room receiving intravenous RTPA unless a neurologist to confirm symptoms of stroke and time onset. The neurologist in duty will arrive to the patient site within 15 minutes and later. Rapid neurological assessment of the patient to confirm symptoms and the time onset. Interpretation of brain imaging with radiology help if needed, and order advanced brain imaging modality and additional lab if needed according to the case, and revise TBA inclusion-exclusion criteria, obtaining TBA consent if needed, and adjust TBA dose and prepare for the medication together with the stroke nurse, and monitor the patients with the stroke nurse during and after the infusion. Also, they will set a plan for management and the treatment decision with follow-up of the patient along the whole chain process till discharge and follow-up in outpatient clinic. And they will provide educational resources to the patient and relative, whether verbal or written. Neovascular intervention on duty will stay tuned and ready for possibility of the need of mechanical thrombectomy if service is available and there is large vessel occlusion in CT angio, and share in its interpretation evaluation for the eligibility of the patient for mechanical thrombectomy. And they can order advanced brain imaging and vascular imaging if needed, even outside the protocol, according to his evaluation for the patient, if the patient is individual entity alone. Radiology doctor in duty, rapid initial interpretation of the brain and the vascular imaging modality when needed, and ensure final reporting of that imaging within 24 hours, but when. Regarding radiology technician, fast arrangement of CT room, MRI room to receive the stroke patients in window. Once code stroke activated without waiting in order of transfer or without delay or separate unless we have code below in that rooms. And perform the requested imaging protocol and also prepare the patients for the different imaging modality. For example, if the patient has metals in his clothes or whatever, he will prepare the patients for imaging modalities. The reporting of stroke labs for patients in window and to whom code stroke activated as each delay may hinder stroke chain process for the delayed lab. If the decision is waiting for it, especially if the patient has past history of renal impairment or the patient past history of bleeding disorder or anticoagulant. The neurosurgery doctor in duty will stay ready for urgent rapid intervention of a stroke patient in special cases who is a hemorrhagic or ischemic who may have malignant MCA infarction, large cerebellar infarction or hemorrhage, and life-saving intervention like the compressive craniotomies, external ventricular drain, ventriculoperitoneal shunt. Regarding ICU doctors, they will receive stroke patients in critical phase and admitted in a stroke unit and general management of stroke patient regarding the hemodynamics, other systems affected, possible complication like aspiration pneumonia, and ordering further needed investigation, consultation with other specialties. All this in parallel with neurology plan of management and according to the guidelines protocol of management of different systems affected in stroke patient till the patient transferred to ward. Anesthesia doctor in duty, they will stay tuned and ready for fast and rapid response for some stroke cases who presented with disturbances in ABCD screening or agitation, disturbed conscious level, or need sedation or careful monitoring, and they need brain vascular imaging under anesthesia, and of course, they will be present on case lab. Regarding the pharmacy, they will ensure the availability intravenous thrombolytic therapy all the time and antiplatelets, aspirin, clopidogrel, ticagrelol, various kind of antiplatelets which may be required for stroke patients, statins, oral anticoagulants. Also, they will ensure the availability of anti-epileptic drugs, especially infusion medication, levetiracetam, phenytoin, benzodiazepine for seizures that may be presented early as a presentation of a stroke or may be delayed for stroke patients as a post-stroke seizure. This may occur in emergency department or stroke unit or ward and should be available as emergency medication plus other required medications. Regarding the nutrition, we will ensure adequate nutrition plan in hospital and at home on discharge with verbal printed educational resources. Nutritional care for our patients may be through nasogastric tube, percutaneous endoscopic gastrostomy, or be both with the patient on NPO and he will receive TBN. Regarding physiotherapy, rehabilitation therapy, we will start the early physiotherapy plan in hospital and the follow-up plan in outpatient, and verbal printed educational resources will be given to the patients and relatives, and provide access to other rehabilitation services, especially speech occupational therapy if needed. How to monitor such performance? It is very essential to monitor code stroke performance for continuous improvement of the process of care. So the key performance indicator like venous thromboembolism prophylaxis for all stroke patients, measuring door to CT time, which standard less than 25 minutes, door to needle time less than 60 minutes in those receiving intravenous thrombolytic therapy, admission to of stroke patients to stroke unit as it improves the outcome of stroke patients, door to transfer to stroke unit less than 3 hours, use of various kinds of scale, especially NIHSS scale for all stroke patients to monitor stroke severity and follow up. Screening all stroke patients for dysphagia using dysphagia screening tests. Also, discharge of non-cardioembolic ischemic stroke patients on antiplatelet. Discharge of ischemic stroke patients on statins based on the target low density lipoprotein. and discharge of cardioembolic stroke patients with atrial fibrillation flutter on anticoagulants, and providing patients and family education with various methods, discharge with access to rehabilitation service, screening all stroke patients for post-stroke depression. And now I come to the end of my presentation. Hope to have a fast journey about the plan of stroke care, especially in acute phase for all our health personnel. It is a basic presentation, basic lectures for our health personnel. Thank you so much. And if anyone wants to ask questions, they are more than welcome in order to give questions to our speakers.
Thank you, Dr. Muhammad. And after you take the questions, kindly Dr. Islam now is joining us. Please, if you want to introduce him after you finish, please.
Okay, if Dr. Islam is available, we can start with Professor Dr. Islam Al-Dusuqi, if he is available and can give his presentation. Dr. Islam, he is consultant at Saudi German Hospital Madinah, and he is lecturer at Tanta University, Neurology, Neurovascular Intervention, and will give us about presentation about tips and tricks regarding mechanical thrombectomy in stroke. Dr. Islam, you can start if you are ready and share your screen.
السلام عليكم. دكتور محمد سامعني؟
Yes, I hear you well, Dr. Islam.
Okay. Suppose that I shared my screen. Is that okay?
Yes, it's okay. Could you make it full screen, please?
Okay, I will. Is that okay now?
Yes, it's okay, Dr. Islam. You can start.
Okay. Thank you very much. Thank you for all the participants in this great symposium. And sorry for the delay. This is not my time to give my lecture, but sorry for that. The internet was so bad. Today, our lecture is like a collection of what is the tricks in the endovascular therapy of acute ischemic stroke. As we know, in acute ischemic stroke, the endovascular therapy, it changed the morbidity and the mortality related to this catastrophic and devastating disease, which was causing a lot of morbidity without the endovascular therapy. The beginning was the intravenous thrombolytic therapy, and it was completed by the endovascular therapy. But still, there is a lot of controversies in specific situations related to this technique. Even till now, some of those controversies are not solved. And we will focus on some of those controversies and introduce bills of how to do in such situations, especially that some situations are very difficult even to detect. This is some of the devices that was used and used now in the endovascular management of acute ischemic stroke, beginning with the Mercy device that now is not used no more, and the aspiration devices, and the most used device in the endovascular therapy of acute ischemic stroke, which is stent retrievers by all of its types. Our lecture today is about, as we said before, controversies. We'll talk about the tandem lesion. Till now, there is no direct solution. Patients presenting with low NIHSS score, in spite of low NIHSS score, they harboring a large vessel intracranial occlusion and need urgent endovascular therapy. Also, what to do when the occlusion is distal, not in M1, not in M2, proximal M2. The guidelines only about M1 for endovascular therapy, but we have encountered a lot of M2, M3 occlusions. Acute basilar artery occlusion with the end of the basic trial to do rescue intracranial stenting in some situations, to do or not to do. Anesthesia, either to use general anesthesia while doing the procedure or only do conscious sedation. And the endovascular thrombectomy versus bridging therapy in proximal vessel occlusion, either to do only endovascular therapy, direct angiosuite, and direct endovascular therapy, or to begin with the intravenous thrombolytic therapy as guidelines saying and pointing, or go direct. This is in the proximal vessel occlusion. First of all, the tandem lesion, the definition is the lesion that harboring both cervical internal carotid artery occlusion and distal intracranial artery large vessel occlusion. As we know, that 20% of the stroke has tandem lesion. We have a stroke in the middle cerebral artery and anterior cerebral artery, and then at the same time we have occlusion of the internal carotid. Mostly the occlusion is chronic atherosclerotic plaque occlusion, or even dissection with artery-to-artery embolization presenting with middle cerebral artery occlusion. This is a very common situation which is facing the interventional neuroradiologist, and there is a lot of debate about what to do, to go first to the lesion or to do angioplasty after going first to the lesion, do stenting or only angioplasty, or just pass with the wire. There is advantages and disadvantages for each of these techniques, either conservative technique only to pass, or also the stenting or angioplasty technique. Here we have occlusion on the left internal carotid artery, also in the middle cerebral artery. So we have tandem lesion. The patient presenting with stroke with an IHSS 13. This is CTA with a good tissue to preserve and to secure and to survive. This is the angiogram showing that the left internal carotid artery is occluded, and mostly it is an atherosclerotic plaque. What to do? To go direct to the middle cerebral, or to do angioplasty and go direct, or to go to do solitaire stent retrieval thrombectomy, and then again to go back to the carotid lesion. This is what we did in this case. Always go direct to the intracranial lesion, because it is the presenting lesion. So do the stent retrieval technique, do thrombectomy, and then go back to the carotid, either to go to do angioplasty plus or minus stenting. If you pass the lesion without even doing the angioplasty, you can just do this, and after you go to the intracranial lesion. If you cannot, you have to go to do very smooth and very mild angioplasty, just to pass, not as a treatment. For the conservative management without stenting, the rationale for this is most of us can pass only with the wire through the lesion, so there is no need for angioplasty or stenting. The collateral circulation mostly is working, because mostly those lesions are chronic lesions, so there is no need to open the carotid now, because the lesion that causing the symptom is only the intracranial pathology. The rationale to do angioplasty plus or minus stenting is that if you do this, you will increase the antegrade flow, and this is aiding the recovery. There's some research and some study that confirming when you do angioplasty or even stenting with the carotid lesion presenting with intracranial stroke, this will increase the blood flow, and this will increase the recovery and the improvement of the neurological deficit that come after stroke. But also when you do stenting, you have to use double antiplatelets, especially if you are giving the thrombolytic lesion. You may increase a chance of symptomatic intracerebral hemorrhage. So what to do? Conservative or angioplasty and stenting. Most of the researches confirmed that it's better to just bypass the lesion, either with the wire if you can, or smooth angioplasty in the acute phase. Not to use double antiplatelet with the acute stenting, and again after 1 week of the thrombectomy, you can go directly to the stenting and use the double antiplatelets if the patient is stable, which is better. You have the benefit of very early recanalization of the carotid with a good recovery showed in some of the studies. And together you avoid to use double antiplatelets in the vicinity of the acute ischemic stroke with an intracranial occlusion. Patients with low NIHSS, sometimes you are encountering in the ER patient with NIHSS even 2 or 1, only mild dysarthria. And if you do the vascular imaging in the acute stroke event, you will find middle cerebral artery occlusion or basilar occlusion, especially in the basilar artery territory. In this situation, the patient has a chronic occlusion, and that's why the collaterals is working, and beginning of acute occlusion on top of chronic lesion, the collateral is ongoing, but finally the collateral will fail. That's why you can see the patient with only NIHSS 2 or 3, and the patient has a catastrophic large vessel occlusion. So take care. Always in this situation, think about the vascular territory, and you have to do an imaging for the vascular territory, even with a patient presenting with low NIHSS. This is patient in our hospital, Saudi German hospital. This patient is presenting with mild dysarthria and very mild right upper motor neuron facial. So you can give him low NIHSS, and it is only 2. This is his MRI. Only the lesions are there. Very few dots in the region of the putamen here in the left side, and even the flares, there is no lesion, but you see the middle cerebral artery signal is abnormal on the left side. You have the clot here in the left M1. And when you do vascular imaging, you have a surprise, which is here, the occlusion in M1, very proximal M1 occlusion, in spite that the patient has NIHSS of only 2. The patient, unfortunately, have no endovascular therapy because of refusal of his family, and the conservative management began depending on the collaterals, but the collaterals finally fail, and you have almost all MCA territory. So take care of low NIHSS presenting patient. You may find a large intracranial vascular occlusion, and you do not know. So what is the rationale for conservative management? That most of the patients have recanalization, even spontaneous with a double or even single antiplatelet. This is shown in multi-center cohort study, showed that there is no improvement in the outcome even while doing the endovascular therapy in such patients. So you have a chance of recanalization, and also even if you are intervening very early with low NIHSS, they found that there is no improvement in the functional outcome. And if you do it early, you have a risk of clinical worsening, and also you have a chance of increased symptomatic intracerebral hemorrhage. So what to do? It is better to assess the collaterals, because the solution is always in the collateral. You have to do CTA to see the vessel occluded, and to do CTB to know is there a tissue of risk of ischemia or no. Is there a thrombus extension or no? If you have a good collaterals in the CTA and you don't have any salvageable tissue in the CTB, so you have to wait and see. You have to begin your conservative management, but in the same time, you have to follow the patient so carefully. If you found any deterioration in neurological status, you have to go directly to the endovascular intervention, because some patients have no recanalization. So you have to see the pathology, see the full picture with the CTA and CTB, and accordingly your decision either to go direct to the angio suite and to do the thrombectomy, or to wait and follow the patient. If deterioration happen, you have to go. This is a biplane angio suite machine, Philips machine. Sometimes the third situation, you have a distal occlusion. You have the thrombus in the M2, M3, even very distal M3. The guidelines do not, recommend to go to thrombectomy in such situation, but still, some M3 branches or the branches in A3 or the distal branches in the posterior cerebral harboring a very high morbidity and even mortality. If you have a lesion in the temporal lobe and you have a large ischemic infarct, you may have an edema and even you have to go to craniectomy in some situations. Also, if you have a lesion affecting the brachycentral and central area and the angular area, you will have a catastrophic language affection, and also you will have a very morbid focal deficit that will continue with the patient whole of his life. The rationale is to only use intravenous thrombolysis is that in the distal lesions, you have a very successful rate of recanalization with only the intravenous thrombolysis. But still, some patients do not recanalize and they have to go to the endovascular. The problem was in the endovascular is the stent retriever was a little bit large with 4 and 6 millimeter diameter. So you have a very high chance of dissection and complications like intracellular hemorrhage when you go to M3 or M4 lesions. The bail is to what to do in such situation. It is your decision to see the patient as a whole. If you have a very young patient with clinically catastrophic morbid deficit like hemiplegia, aphasia, and also you have a very distal occlusion, so there is no chance for the collaterals to work, you have to go to the thrombus and to get the thrombus. Especially you can use a very safe technique without a stent retriever, which is contact aspiration using the penumbra or other aspiration machines. Or even you can use the stent retriever or if this contact aspiration fail, and you can use the new stent retriever systems like the small diameter stents and go very smooth and to be very careful not to have a dissection while doing the thrombectomy. So you have to go to the thrombus, very careful. Contact aspiration is better than doing a stent retriever technique. And even if you go with the stent retriever technique, you have to go very careful, very smooth, not to have a dissection and catastrophic intracerebral hemorrhage. In the situation of acute basilar artery occlusion, which constitute about 20% of our patients, not only the percentage is important in the basilar artery, the most important in the basilar artery is the catastrophic result. The mortality rate in the basilar artery occlusion is about 80 to 90%, and the morbidity is very high. Most of the patients either die or go to vegetative state or locked-in syndrome, which is very catastrophic. We all know that the BASICS trial or study is the biggest trial that compare between the endovascular technique and the bridging technique. But unfortunately, the result of the BASICS is not encouraging at all, and the result was not good regarding the endovascular therapy for the basilar artery occlusion compared to the anterior circulation. But in opinion of most of the researchers, and there is like analysis for the BASICS result, they think that the selection of the patient was very bad. The selection was skewed towards the patient with more doubtful prognosis. So the selection of the patient in BASICS trial was not good. That's why the results of the endovascular technique is not as expected, which is very unlogical. So still the current guidelines, if you have a basilar artery occlusion, you have to go to do thrombectomy and to use the imaging technique, the good imaging technique, to see if there is salvageable tissue or not. You have to go with all means as a trial to open the basilar artery. We have also an issue which we encounter in the patients while doing the thrombectomy to our patient, which is the intracranial atherosclerotic stenosis. Sometimes we go to have the thrombus and we cannot, and only while doing the stent as opening the stent, we have a very good recanalization while the stent is in place. When we do the thrombectomy, we have the thrombus in our stent thrust, but when we go to the angiography after stenting, we have the artery is again occluded. We have to suspect in such patients, especially if they are presenting with low NIHSS score, to suspect that there is an underlying intracranial atherosclerotic stenosis that will again re-occlude the artery. So we have to know if it is only spasm or it is an intracranial stenosis, and we have to go to rescue intracranial stenting. About 29, which is very high percentage of our patients, have an underlying intracranial stenosis, either calcified adherent thrombotic thrombus or even dissection. And in this patient, we will find them young patients, mostly in Asian patients. Most of these patients in the basilar artery territory, most of them presenting in low NIHSS because they have a chronic atherosclerotic lesion. So they have a very good collateral that makes them presenting with a low NIHSS score. So we have to take care in such patient. If we have very high residual lesion, we have to confirm is that a spasm or a true lesion, intracranial atherosclerotic lesion or dissection. We have to go, if we are confirming that it is an intracranial atherosclerotic lesion, not a spasm, we have to go to do an angioplasty, very careful, and even to do an stenting. There is a very large study shows that there is percentage, when there is percentage stenosis, there is a very high chance of reocclusion, even if the lesion went gone while doing the follow-up MRI and found no ischemic lesion in the period of 7 days after the endovascular recanalization using only stent retriever. We have a very high chance of reocclusion, and we have to stent those patients not to have a catastrophic reocclusion after 7 days of our successful thrombectomy. And the study also found that even with using the IV thrombolysis in the setting of acute stroke and using the double antiplatelet in such situations, we have no increase in the intracranial hemorrhage if we do stenting for such patient. This is an example of this intracranial atherosclerotic lesion. This looks like M1 occlusion. This is after recanalization, after thrombectomy. We have here a very irregular, here is dilated, here is very thin, and it looks like there is there is something here. If we do again very focused angiography, we have a very tight stenosis here and the atherosclerotic block here. Most of the patient will reocclude again in the setting of acute stroke. This is after stenting, after smooth angioplasty, and after stenting, and the patient went very well. This is another example with more common presenting basilar artery intracranial atherosclerotic lesions, and this is again the result after angioplasty and the stenting after getting the thrombus. To use general anesthesia or either local anesthesia in the acute ischemic stroke, a lot of debate is about this, and most of us have their own method. Some of us makes local anesthesia and conscious sedation. The advantage of this is to see our patients while doing the procedure, is to see the deficit, to see if the deficit is increasing, to assess the neurological status while doing the procedure. And this is very important. If we have a catastrophic complication, we will find our neurological deficit increasing. Also, the hemodynamics. If we don't give general anesthesia, we can keep our blood pressure like we need. We cannot have hypotension because of the general anesthesia and the pro-anesthetic drug, which is a drawback of general anesthesia. The drawbacks of the general anesthesia is that we cannot assess our patient's neurological status, we cannot assess his consciousness, we cannot assess the neurological deficit. Also, the hemodynamic can be compromised because with the pro-anesthetic drugs, we can have transient hypotension, which can be very harmful for the patient and compromise the collateral flow and get worsening of the ischemic lesion, get worsening of the neurological status of the patient. But with the local anesthesia, if the patient is disturbed, we can have a very high chance of aspiration and bronchopneumonia and endangering the patient life after even the successful procedure. So what to do if we have a very good anesthesiologist in our center and can proceed to the general anesthesia very rapid, not to waste the time, and also to keep our blood pressure as we want and know what to do. It is it is better and very good to us as an interventional neurologist to work in while the patient has general anesthesia, because the patient while doing the procedure, it is very painful, especially inside the intracranial vessel. So he can have a very severe pain. So it is better not to have this pain. To assess the neurological status, we can assess the neurological status even while the patient is on general anesthesia by assessing the soft neurological sign. We can know if there's deterioration from the tone. We can look regularly to the pupil, so we can assess the neurological status, but indirect. So if we have good anesthesiologist, which is available in which is available in our hospital, doing the general anesthesia in almost 3 minutes and keeping our hemodynamic stable, we can go to the general anesthesia. If we don't, we have to go to the local anesthesia and conscious sedation. And if we have the patient during the procedure is not cooperative, moving a lot, we have to go to do the general anesthesia to protect the airway, not to have aspiration and the bronchopneumonia. Now with the proximal vessel occlusion, to do intravenous thrombolysis as guidelines say, and go to the endovascular to do bridging or to do direct to the angio suite, especially in the future, I think we will have an angio suite with very high quality CT brain like the other machines. Even maybe we'll have like software that we can see the CTB on the angio suite. So what is the need for the intravenous thrombolysis? We can go direct when the large vessel is occluded, direct to do the thrombectomy. But till now, there is a lot of research saying that using the intravenous thrombolysis is a must because it dissolves a part of the thrombus, so enable us to get the thrombus very rapidly and the more easier with our thrombectomy, with our endovascular technique. So still it is helpful and not increasing the chance of symptomatic intracranial hemorrhage. The difference between using the intravenous thrombolysis alone to get, or bridging therapy regarding symptomatic intracranial hemorrhage is very minimal. So still we have to use intravenous thrombolysis. Maybe in the future we have to proceed direct using the endovascular technique. This is a case that received the intravenous thrombolysis and the endovascular technique with very good recanalization, but unfortunately the patient has a large intracranial hemorrhage and proceed to craniectomy to resolve the edema and the pressure. This can happen, but still we have to use the intravenous thrombolysis if the patient came in the window and the criteria can be fulfilled to use the intravenous thrombolysis. Maybe in the future, the intravenous thrombolysis can be changed to a more rapid onset and even more or less symptomatic intracranial hemorrhage. Maybe also we have more technical issue regarding endovascular and more successful localization. And also it is very important how it is rapid to get the thrombus. if you got your patient and give the intravenous thrombolysis, for example, within 3 hours, and go to get your thrombus with the endovascular technique, you have to get it from 30 minutes to 1 hour. If you have a prolonged procedure, it is a catastrophic because you don't know what is going on. Maybe if you have a prolonged procedure, the patient already have ischemia, and you will go only to do a recanalization injury, and your patient will have harmful edema or intracranial hemorrhage. Even the techniques, there is a debate about techniques. Almost all of us using a combination, but still some begin with the aspiration, just to have the aspiration with the aspiration techniques to be on contact to the thrombus and to get the thrombus by contact aspiration. Some of us go direct to stent retriever. Some of us go to do combination of both technique, doing them together, what is called subnumbra, to use contact aspiration while opening the stent. Some of us doing the techniques in a successive way. If technique fail, we have to go to another technique. This is the angioplasty when we have intracranial atherosclerotic lesion. So the techniques which we can use, the mechanical thrombectomy technique, which is the stent retrieval, which is the most commonly used and I think the most successfully technique. The Mercy is no longer used. Distal aspiration thrombectomy either use the adapted technique, which is direct large bore catheter aspiration without balloon gated catheter as a guider, or to go to a manual aspiration using the older penumbra system. This is the Solumbra, or using the stent retriever technique together with the aspiration catheter, which is penumbra in this case. There is a very good technique. I think this is the most important and the most successful and the most protective technique, which is the protect technique. It uses a balloon mounted very large core guider catheter to obstruct the flow while doing the thrombectomy technique to avoid the distal embolization, to arrest the flow while doing the thrombectomy, together with using the aspiration and the stent retriever. This technique, which is called Protect, is a very highly successful technique. As we said before, with the distal thrombus in the M2 or M3, we have now systems or stent retriever like system with a very good protection, like the filter which you can use in the carotid stenting technique. So you are opening the stent, and also you have a mesh or something distal that can hold your distal embolization not to go distal while you are doing the thrombectomy. We have a lot even of stent retriever with different design, with different diameters, with different lenses, with different radial forces. We have to choose between the different stents, and we have the last technical advances in this issue, which is the input trap or the golden retriever. We have the stent inside, and also we have something to trap the distal embolization or the part of the thrombus that can embolize distal while we are doing the withdrawal of the stent retriever, which is very good because sometimes we have distal embolization while doing the thrombectomy, and even we have to go to do it, and this is very technically demanding, and will increase the chance of intracranial hemorrhage and the chance to get deficit from the distal embolus, not from the proximal occlusions that we already successfully recanalized. And even with the catheters that we can use, there is a very different large types of catheter. We can use ACE, Sophia, a lot of catheter with different again design. Every catheter has its advantage and its disadvantages, and it is according to the preference and the use of the neuroradiologist. It is better to use what you are adapted to do most often, because it is always successful, even if it is less technically advancing than the other guiders. And this is also the aspiration system. We had only the penumbra in the past. We have now Medtronic aspiration system, which you can use instead of the penumbra aspiration system. This is some of the debatable issues related to the endovascular thrombectomy, and I think in the future it will come with a lot of changes, a lot of advances, and we can change this a lot regarding the endovascular thrombectomy and regarding treatment of our patients. And the guidelines are changing every few years, even every year. We do not know what will happen next, but we have to do our best for the sake of our patients. And thank you very much. And sorry for the long time of the presentation. And thank you, Dr. Muhammad.
Many thanks to you, Professor Dr. Islam al-Dasuqi, for that interesting presentation about controversies, tips and tricks in mechanical thrombectomy and ischemic stroke. And I think all specialists interested in the field of neurovascular intervention, today it was full dose updated info, full dose hot topics in that field regarding mechanical thrombectomy, which needs more and more specialized neurologists. And we brought to you the experience from different parts of the world, different schools. All of them put their experience between your hands through that stroke symposium. Many thanks again to you, Professor Dr. Islam, and many thanks to all our audience who attended our 3 days of International Stroke Symposium. It was fruitful, various, a lot of presentation, informative, going through the whole parts of stroke and whole topics of stroke, like the title of our stroke symposium, the hiking guide in stroke mountain, as the field of stroke medicine is a big field with have a lot of mysterious subjects in that field, and need more and more research, more and more experience from daily clinical practice. Guidelines always changing. Everything is progressing rapidly in such a field. So we were like the one who climb a big mountain, and that symposium trying to put you on the road like the guide in order to have sound clinical practice for the benefit of the patient and the benefit of their families. And this is the main mission of all strokologists. We have no questions in our question and answer taskbar, and I have now to end our stroke symposium. Many thanks to Academic Affairs in Saudi German Hospital Madinah for organization of such big events. Many thanks to administration of Saudi German Hospital Madinah. Many thanks to stroke team, all the specialties involved in the stroke team in Saudi German Hospital Madinah. Many thanks to our speakers. Many thanks to our audience. We hope to meet you again in further scientific activities, maybe live activities or virtual activities, but be sure that the usefulness is guaranteed in all our stroke webinars, and we will go through various stroke workshops dealing with specific subspecialties regarding stroke medicine and all neurology diseases or systems like neuromuscular, like inflammatory demyelinating disorder. We are keen in your usefulness and beneficiary from our scientific activities. Hope to enjoy your day with such in, and hope to meet you again in the nearest future activities. Thank you, Dr. Islam. Thank you, Mr. Ale. Thank you, all Academic Affairs. Hope to meet you again. It was nice organization. Thank you.
Thank you, Dr. Muhammad, for everything. Thank you for our eminent speakers, and inshallah we'll meet our audience. Inshallah, next month we have a new event in SGH Madinah Cardiology Symposium. Inshallah, it will be in August. Thank you for everything. Alhamdulillah, الذي بنعمته تتم الصالحات. We finish our 3 days. Our brilliant Dr. Muhammad, he was moderating the 3 days, and our speakers, our eminent professors and doctors. Thank you a lot, and Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.
Alaikum
Thank you.
assalam.
Thank you. Thank you.